I welcome you all once again to the AFOMP webinar. So now I introduce Professor Arun Chogle, President of AFOMP, to formally welcome you and start the session for you today. Thank you so much to Professor Chogle.
Dear participant, welcome to this AFOMP series of webinar we have started since June 2020. And this is because of the COVID-19 situation. In person, physical meetings are not possible, and we don't wanted our teaching and training should discontinue, and we have chosen the path of virtual webinar. Today's webinar was to be conducted by Jin Xians, the chair of ETC, but he had some urgent work, and because of that he couldn't make to it, and he asked to introduce and do this thing. So today's webinar is by Dr. Sung Yong Park, who is working in a proton therapy center at Singapore National Cancer Institute, and he will be speaking on comprehensive proton therapy machine quality assurance AAPM TG 224 report, of which he was one of the author also. To conduct this webinar, today we have Professor Haseen Anupama, who is the professor of medical physics at Dhaka in Bangladesh. She is also the Secretary General of AFOMP. She has a wide experience of medical physics and training. Without spending more time, I hand over the mic to Anupama for conducting the webinar. Professor Anupama.
Thank you, Dr. Arun, for nice introductions. Good morning, good afternoon, and good evening. Please accept my warm greetings to all the participants. We are very delighted to see that many participants has attended today's webinar from the AFOMP region and beyond the AFOMP regions. Just previous like our seminars, webinars, we know that the participants who will attend this webinar will get 2 CME points and as well as certificate within 1 to 2 days after end of the webinar programs. So you will find a link, registration link for your CPD link. Please do click the link and you can fill up the forms, your names, which exactly will be shown in the certificate, and then please send to us. So we are very delighted to have our speaker today, and this is very current and advanced topic that is on proton therapy. You know that proton therapy is the most precise and advanced form of radiation therapy in the available today. In the worldwide, everywhere, the proton therapy center is increasing day by day, not only in developed countries, but also in developing and least developing countries are thinking to establish the proton therapy center. We all know why it is, because it can deliver in higher doses and with far more accuracy, and can typically control cancer with fewer treatments than IMRT. And also it results in fewer long-term side effects, as the radiation does not spill over and damage healthy tissue and organs due to its back peak activity. And we are very fortunate that to have our honorable speaker, Professor Sung Yong Park, who is also one of the author of the AFOMP Task Group 224. You see, can you see my slide? Is it visible?
Yeah, visible, yes. visible and audible both.
Okay. So this is AFOMP Task Group 424, Comprehensive Proton Therapy Machine Quality Assurance, and Professor Sung Yong Park is the one of the author. So you know that before clinical operation, it is very, very important to know the installation quality assurance procedures of any radiotherapy machine. So today's webinar, I would like to introduce some of the things of the Professor Sung Yong Park. Professor Sung Yong Park is a He has over 25 years of clinical working experience from several institutions and has held chief positions in 2 institutions for over 16 years. In the last 2 institutions, he oversaw the operation of X-ray and proton therapy programs, including satellite centers. During his career, he has been involved to setting up programs at 2 new radiation oncology departments, including proton therapy, IMRT, IGRT, SRS, SBRT, and has been instrumental in selection, commissioning, acceptance, and work for the McLaren Proton Therapy project in the United States. And he has established, in addition, the first medical physicist resident and fellowship program at National Cancer Center in Korea. His research experience in the field of has led to his development with several prestigious groups, including membership in the IEC TC62C Working Party on Light Ion Therapy, APM task group number 224, and etc. He has published more than 117 research articles and given more than 77 invited talks. He has several research grants and patents. His current research interests include range uncertainty, automation of true beam quality assurance, proton imaging, and image guidance proton therapy. So ladies and gentlemen, we are very honored to have with us today. And now the title of his talk for today's webinar, Comprehensive Proton Therapy Machine Quality Assurance TG224. So thank you, Professor Sung Yong Park. I would like to request you to give your valuable speech, and the floor is now yours. Thank you, Professor Sung Yong.
Okay, thank you very much for your great introduction. Let me share my screen first. Can you please?
I'd like to ask participants, please mute your microphones while the speaker will deliver his lectures. And also, if any questions or any query, please leave it in the chat box. Please do not unmute.
Could you,
Anupama, you have to unshare your screen so that
yes.
Professor Sung Yong can share.
Yes,
yeah.
I have stopped my
okay,
screen.
thank you. Okay, so let me share my screen here. Can you see my screen?
Yes.
Okay, great. So thanks AOMP for inviting me. For me to talk about the machine quality assurance. Hello, everyone. Thank you all for being here today. It is my great pleasure to talk about the proton therapy machine QA. As a lot of facilities are under construction and planned in this Asia-Oceania regions. So there's a certainly huge interest in proton therapy. So this is, I think, the right time to talk about the proton therapy quality assurance. Okay, so what I'd like to do today is I'm going to start with a very short introduction for the definition of QA and then new international standard by ISO, and then why different types of QAs are needed for, in particular for proton therapy. And then in the next session, I'll be talking about the proton therapy machine QA based on AAPM task group report 224. And in this section, I will also briefly introduce the fundamental concept of proton therapy for those who are not familiar with this proton therapy machine, and then delivery techniques and some of the important features I'll be talking about as well. And you know, it is impossible to talk about everything for proton therapy machine QA. So, but I will talk about mainly for very important aspect of proton therapy machines. So hopefully I will have enough time to introduce our current ongoing proton project in Singapore here. Okay, so in radiation therapy, I'm pretty sure that everybody is familiar with this item. You can see here. Okay, so I can group into that radiation source, such as from the cobalt machine up to proton and heavy ion, and radiation delivery techniques, 3D CRT, SRS, and IMRT, and IMPT, and patient positioning for IGRT, 4D treatment gating and tracking. So as a new technology has been developed or implemented, so the QA significance is also increasing. So therefore, if we have a good radiation source, such as protons or carbon ions, or good radiation delivery techniques, such as IMPT or IMRT, a good patient positioning method, such as 4D gating and tracking method, and moreover, good physicians with a good experience and good physicists for quality assurance, and our patients can receive the best treatment. Okay, so in 1986, ISO has defined QA as all those planned on systematic actions necessary to provide adequate confidence that a product or service will satisfy given requirement for quality. Years later, sometime in 2015, ISO has introduced a new international standard. It's called risk-based thinking, which is a systematic approach to considering risk rather than treating prevention as a separate component of a quality management system. So the risks are identified, considered, and controlled throughout the design and the use of quality management system. So this is a new trend, and I'm pretty sure that our community and our society is moving this direction. So for those who are interested in reading this article, please do so. So it'll be helpful for our QA management. Okay, so physicists are not the only one group to work on QA program. It is really indeed need including all the staff members in your department, such as administrators, ROs, and nurses, and medical physicists, and therapists, to build a really very comprehensive QA program. So the quality of all aspects of patient care include the services. For example, taking patient data and making appointments, diagnosis, treatment planning, treatment and follow-up. And the products can be, customized beam blocks, immobilization devices, and so on. And then up to the treatment and then follow-up. So it is really recommended to establish the QA committee in your department and to have a discussion on your QA program, improve the quality of the program, and to also discuss about any incidents you might have. So also it is recommended to have a meeting on quarterly basis, and the documentation such as policies and procedure manuals are also needed. And moreover, at the end, maybe a yearly or maybe biannually, it is required to get a quality audit from other organizations such as ACR or APEX or whatever. Okay, so now let's talk about the proton therapy. What is a proton therapy? Accelerated proton beams are used for the treatment of cancer. I'm pretty sure you have seen this depth dose comparison graph between different modalities. As you can see here, proton stops at the end of the beam range, at the bright peak range. So protons have a finite range. Okay, so this is a new data I obtained from a PTCAG website. At that time, when I started first proton therapy, it was only something like 23 proton therapy centers in the world. As you can see, the number of proton therapy centers and carbon ion centers are increasing dramatically, especially in our region also. As you can see, in every country, and every institution are trying to build a new proton therapy or carbon centers. So I will talk about this a little bit later. Even in Singapore, we have 3 ongoing proton therapy projects. So there's a huge interest. Okay, so why people are so much excited about this proton therapy? So here's a simple study we have performed years ago, published in Red Journal. So cranial spinal irradiation using 3D component radiotherapy, tomotherapy, and proton therapy technique. So regardless of what X-ray therapy technique you have used, still you have delivered certain amount of radiation dose to the healthy organs. But whereas since the proton beams are stopped, so there's no dose to the healthy organ. However, range uncertainties in proton therapy are the biggest challenge and can be substantial. So here's an example in the case of introducing the inhomogeneity material in the beam path of photon beams. And then it may disturb some proton therapy depth dose by 2 to 3%. But whereas, if introduce same amount of inhomogeneity material in the beam path of proton beams, and then you may lose your target coverage. So meaning that for the worst scenario, the 0 dose to be delivered to your target. So this is very important concept. You should be aware of this. So proton therapies are shown to be a precise and practical method for delivering highly conformal radiotherapy. However, it is guaranteed for the degree of accuracy and reliability required in proton therapy if a robust quality assurance program is established. It has some similar features with the QA in the conventional radiotherapy. However, but there are some aspects are unique for proton therapy. So let's talk about the proton therapy machine QA based on a task group report on 224. So task group 224 charges are to develop comprehensive quality assurance guidelines and recommendations for the 3 commonly employed proton therapy techniques for the beam delivery, such as scattering, uniform scanning, and pencil beam scanning. And also to establish QA guidelines for therapy machine performance for other widely used modalities, such as photons, electrons, and shares the aims of ensuring the safe, accurate, and consistent delivery of radiation therapy dose distribution to the patients. So task group members consist of 13 members from all over the world. And really, indeed, we work very hard to produce such a guideline. So it was chaired by Bijan Arjomandi from US. So we start our task group from 2012, and it took 7 hours to publish this paper. So it was a very lengthy report. I think it's close to about 28 pages, but originally it was more than 28 pages. We have gone through more than 20 times revisions by multiple users from our society. So finally, it came out last year. And we met each other through a conference call on a monthly basis, and physically we met in the AAPM meeting to publish this paper, okay? Yes, really we put a lot of effort to produce this guideline. And it is available in the website, so you can just Google AAPM task group report, and then you can download this report without any charge. Okay, so the table of contents includes basically including some of the basic principles and delivery techniques and some of the treatment parameters and dosimetry parameters, and then it basically contains a lot of information. So even though you are not familiar with this proton therapy, still you will get some very basic knowledge of proton therapy from this report. So what we are trying to do also try to cover all the different types of machines and different manufacturers and different options they have, because proton therapy machines are really not standardized as compared to X-ray machines. So it has a different option, even though it's the same company. However, you know, the technique could be different from one institution to the other. I'll talk about this a little bit more later if I have chance. Okay, so as I mentioned, that the number of proton therapy centers has grown rapidly, and so therefore the comprehensive QA is needed to ensure that patients are treated safely and effectively. Therefore, the APM report group was established to define QA procedures. And this task group considered the various technologies and design characteristics implemented by different manufacturers, as I just mentioned before, and then has determined recommended tolerances and ranges for parameters. Okay, so this is important things to remember and directly influence the accuracy and precision of proton beam therapy delivery. So the frequency of various measurement and tests to be performed by risk assessment analysis, which is the new trend and the new direction of QA program in conjunction with the task group report 100 from for FMEA analysis as well. Okay, so the methodology of QA, briefly talk about this. And then there are three key branches of QA, which are general equipment functionality, including dosimetry, imaging, and mechanical QA, and patient-specific QA, which is very much similar to IMRT or VMAT types. However, for proton therapy, in general, we do patient-specific QA and multiple plans. Okay, and then treatment planning system QA, which was described in TG53 report. So I think you can refer to that. So in this session, mainly I'll be talking about the first part, which is general equipment functionality on that. So the machine QA procedures are dosimetry parameter checks, which monitor absolute observed dose to the target and relative dose distributions. And mechanical checks and imaging system checks are also very important, and safety checks are also considered as very, very important. Okay, so any of the recommendations may be modified for different frequency to accommodate unique machine characteristics and the requirement for each individual institution and organization. So meaning that you need to build your own QA program based on your functionality of your machines and capability of your machines as well. So in other words, you need to understand your system quite well in order to perform all the required tests and measurement. Okay, so let's just briefly go through the proton therapy basics. Okay, so there are mainly two types of accelerators are currently being used, either cyclotron or synchrotron. You see the picture here. Cyclotron manufacturers are mainly by Sumitomo and IBA. In other words, they are basically the same machines. And the synchrotrons by Hitachi or Proton, or there are some other vendors as well. Okay, so this is a simple comparison between cyclotron and synchrotron, where the energy is fixed. So meaning that you have a maximum energy of a cyclotron. So you need to degrade the energy by using the degrader. However, for synchrotron, you can extract your energy, what you want, and so that your synchrotron speed structure is pulse, whereas cyclotron is continuous. And the cyclotron beam current is very high as compared to synchrotron. So this is some of the very quick comparison in between. So there's a pros and cons. So let's talk about the proton beam delivery technique. See here, there are mainly two types of beam delivery technique. Either proton beams are delivered by passive mode or dynamic mode. So the new proton therapy centers are only adapting pencil beam scanning mode, which is the bottom line, and which is the bottom one here, and then which is the latest technique. However, still there are a lot of centers are running their program by using passive mode. So let me just quickly go through the basic principle of passive mode, where you have proton beams are coming into the nozzle. So this is a nozzle. And then proton beams are broadened by using the first scatterer, okay? And then you have a second scatterer to basically flatten the beam like this. And at the same time, at the distal portion, using the range modulator, you see from the right picture here. So hitting the each bragg peak of different intensity, create this flat top of beam. It's called spread out bragg peak. Okay, so meaning that depends on the size of the tumor, so that you can adjust your tumor the depths accordingly. And for passive mode, also you need to have aperture or MLC to define your shape of your tumor. And then, so distal range, you can use so-called range shifter. So there are many scattering devices inside the nozzle, so that your beam quality is different as compared to pencil beam scanning. Okay. So there's another mode is called single scattering mode, which is not covered this report. However, I can just briefly talk about this without spending too much time, meaning that without a second scatterer. So basic principle is pretty much similar. So we will produce a less penumbra as compared to double scattering. So it's mainly used for a small size of field or such as ocular melanoma treatment. So in dynamic mode, so uniform beam scanning modes are still being widely used. So this mode is relatively bigger size of spot scattered from the first scatterer, and then using the two scanning magnet to broaden the beam and then treat the patient. So in this situation also you need to use aperture, and then the energies are changed by the stacking method, energy stacking method. So the pencil beam scanning mode, again, this is a new type of technique. And then I think most of centers starting from 2015 or a little bit earlier are adapting only pencil beam scanning module. So as compared to either passive mode, the nozzle inside is pretty simpler, so that you can basically extract a very clean beam. So the very small size of pencil beams are coming into the nozzle and throughout the monitoring device, and then basically using the X and Y scanning magnet, and then you can scan your proton beams layer by layer. So it does not require the hardware such as apertures and compensator. Okay, so here's the important dosimetry parameters as compared to X-ray beams. Okay, so the range of the beam in water is also very important to understand this for proton beams. Okay, so the range can be determined by the energy of the proton beams, and then it can be changed by either degrader in the case of cyclotron, and then there is the frequency of the ring in case of synchrotron. So the range is defined as 90% of the position. Okay, and then the distal dose fall-off is defined from 80 to 20% of your dose fall-off. So it is also another important aspect to modify to understand this. So the distal dose fall-off depends on the your beam energy spread and also the scattering material on your nozzle. Now, next we have a spread out Bragg peak, which I just mentioned. For double scattering mode is defined as a 90% of proximal to the 90% of distal portion is defined. So again, this is adjustable based on your requirement for the treatment. So it can be modulated by the so-called range modulator wheel or rich filter or binary filter. So so it depends on the the material, or it depends on the timing. Is it important to verify your clinical aspect? For instance, that when the beams are hitting to the different thickness of range modulator, so if it's out of focus, meaning that if it's hitting out of position or it's not synchronizing it with your timing, and then it may introduce the error, or maybe the coverage may be different. So this is important to verify your SOVP width for your treatment as well. So lateral dose uniformity is also an important aspect, which is similar to photon therapy. And the field size is defined as 50% of dose fall-off. And primarily, it was determined from the scattering material. And then it also depends on your aperture and collimator, or effective source to target, and so on. So the lateral penumbra, which is defined as 80 to 90% of these depths here. So it was determined from the aperture also, and collimator of the beam, and also the effective radiation source, the target, and moreover from the scattering material in the nozzle, and then patient body. Okay, so the depth dose uniformity is also important to make sure that your depth dose is uniform. So it can be changed from different range compensator design, or let's see, or it can be if it's out of synchronization, and then it may be produce a different depth dose uniformity. Okay, so in case of pencil beam scanning, I mean, the pencil beam scanning can be also applicable for the previous cases as well, but this is, we are concerned about more for pencil beam scanning in this slide. Again, for pristine Bragg peak rather than spread out Bragg peak. Okay, so the range, I already addressed some of the issues. We need to check that. And then distal dose fall-off, which was defined 80 to 20% of your dose. And then position of a centroid of the beam profile. For spot scanning, it is important to verify that your position of the centroid of the beam profile is important. It should not be skewed one way to the other, and make sure that your proton beams are well tuned. Of course, in reality, this is not true. Depends on the gantry angle and depends on your energy. So it is important to verify your spot size as well, and then shape of the beam spot, and then again, depth dose uniformity. Okay. So the imaging in proton therapy is also very important. So proton therapy is basically all image guided. I think someone claimed that the image-guided radiation therapy is coming from proton therapy, which is true, I think, in some sense, because at the time of the proton therapy treatment, we start using the image guided treatment. So proton therapy is more sensitive to uncertainties in treatment planning and beam delivery as compared to X-ray therapy. So the accurate imaging in proton therapy is extremely important for treatment planning and beam delivery verification. However, still there are a lot of centers are using KV imaging, and recently many centers are only equipped for volumetric imaging. So again, you know, this is very much required for proton therapy in order to position the patients more accurately with the cone beam CT or CT on ray. However, the imaging implementation in proton therapy is somewhat lag behind as compared to X-ray therapy, because mainly, you know, it's a small size of a market, but now it looks like it's growing so fast. So TG test group report recommends the use of test by TG142 and 179 and MPPG2A to be performed for the image guidance system. So this report is not much talking about the image guided imaging in proton therapy QA. However, the user should refer to TG142 and TG179 and some others. So here's a picture for the imaging system in proton therapy. And these days, you know, there's a lot of new development, which seems to be very interesting. On the ring is mounted on the patient couch, so that you can image, or you can obtain the cone beam CT images from this ring. And then CT on ray is also being used. And then for our system, Hitachi machine, you know, they using offering a tool with the two flat panel detectors to produce cone beam CT and fluoroscopy images and so on. Okay, so how often we need to do QA in proton therapy? It is important based on the risk analysis. I'm pretty sure one can design your program based on our recommendations. So proton beam can be delivered with different machines and different modalities. So failure mode and effective analysis techniques can determine, prioritize the risk associated with errors. So this should implement the risk analysis to evaluate the probability, severity, detectability of an occurrence in TG100. So let's talk about the daily QA. So the QA measurement is basically a consistent check against your baseline measurement for your beam commissioning. So in daily QA, so you basically measure your dosimetric parameters such as output, range, SOBP, and range uniformity in case of double scattering, and communication and imaging and safety as well. So this slide shows a daily morning QA program with the PMMA Phantom we have developed. So at that time, when we start our proton therapy treatment, there's non-patient proton-specific QA devices. So we need to modify our existing, or we need to develop our own Phantom and then treat the type of measurement as well. As you can see here, after the irradiation of some time for proton beams, the colors are changed like that. Okay, so we have developed our own years ago for our proton QA program to check the output and then range modulate to FLIR for double scattering. And so this is interesting device Xiaoning Ding developed with using Sun Nuclear Daily QA3, and then he modified this device by fabricating different size of Phantom so that he can measure the output factor at the same time to obtain the beam range and symmetry and image registration and all kind of very much required QA test can be done with this device. I think this is a very clever idea. He has done this. So many of institutions are adapting this device for their QA program on a daily basis. So let's go over the quickly for PBS daily test. They're pretty much similar, but however, in the case of for PBS, you need to make sure that your spot position and spot pattern is correct. And then the other tests are pretty much similar to double scattering mode. So this is a test pattern developed by IBA user group led by Jay France. And this is interesting test pattern is that to measure your spot analysis beam characteristics by delivering the beams, and then check the spot size, and then gamma analysis and resolution and so on. So again, it is also our goal to reduce our treatment QA time also to improve our clinical workflow as well. So this is a new commercial development from IBA using scintillator-based flap detectors to measure the spot profile and the resolution, introducing different size of the phantom, and then the ion chamber to measure the daily QA requirement in 20 minutes or less. But I think this is a quite expensive product. So this table illustrates the procedures for daily QA program. This for different delivery technique, and most likely it will cover all the options from your treatment beam machines. And it looks like there are a lot of measurement or testing you need to perform. However, you can actually combine with the multiple testing together, so that should be done in half an hour basis. I'm not going to over detail, but however, let's move to weekly QA. And basically, you need to make sure that the trend of your beam output for weekly basis. So this is important to review of daily QA checks, and then some other additional measurements you need to perform. So this is the QA program we have developed for our own for measuring different size of the SOVP and so on. And for PBS weekly QA test, also you can extend your measurement, not just for spot scanning, and then you make a uniform field to make sure that your beams are uniform, and some other additional tests, and then moreover, review of daily QA system. So in the case of weekly QA, I like to emphasize this. In the case of weekly QA, it is recommended to check the gantry angle indicator against your actual gantry angle. Because in the case of patient treatment, especially for obese patient, okay, so if there is a 1 degree off from your gantry angle indicator versus your actual gantry angle, and then you will change the proton beam range. So it is important to disturb your patient dose distribution. Okay, so let's move to monthly QA. Monthly QA also requires more and more measurement, as compared to single beam directions. It is recommended to measure the output and ranges and SOVP with flatness, symmetry on all different angles. Preferably recommend to measure all the cardinal angles, and then to verify your system is functional. Okay, so here's an example for the gantry output for different angle. Because of the beam optics, the beam delivery, it may be different from one angle to the other. So this is important to verify. And then in case of your proton beams with a compensator, range compensator, it is make sure that your milling machines fabricate your compensator as planned by your TPS system. So, most likely it was measured at different depths by using the depth caliper. We have developed our own program with CT images, and later even proton radiography, so that we can measure the distance of the range compensator more accurately. Okay, so again, as I mentioned, the proton therapy is all image guided, so it's important to make sure that your X-rays are aligned well with your proton beams. So you check that, and then we have measured our proton the gantry years ago. So how good isocentricity is our gantry system. So you know that the gantry is about 9 meters long for IBAs, and then it weighs about 160 tons. Then, however, for 360-degree gantry rotation, the isocentricity is less than 0.6 millimeter in diameter. So which is very amazing as compared to even much better than X-ray machines. So in case of PBS monthly test, instead of checking the output accuracy for one reference field, is recommended to take at least 3, and the range accuracy for different size. For example, low and medium and high energies and spot alignment test. Basically you extend your the measurement for each individual test. So in case of pencil beam scanning, so this is the important aspect you need to be aware of, that in case of spot size is sigma is 3 millimeter. If there's a small shift, there's over 50% of this size, and then you may introduce 20% error. So it is important to make sure that your spot position is on right position, and also you need to concern about in case of the motion of the patient. It is very, very important to aspect you need to realize that. Okay, so this slide illustrates the monthly QA program procedures for proton therapy in the different delivery technique. So I'm not going to over detail, but please refer to this tolerance level. So annual QA is basically, it's very much same as your commissioning data. So this is repeating your measurement as compared to your baseline. You want to make sure that they are consistent, they are within the tolerance limit, and then so basically you use the 3D water phantom to measure the integral depth dose or profile and everything you have done similar to X-ray machine. So the dose calibration is recommended to use IAA TRS 398 protocol. It's being widely used for pencil beam scanning and double scattering method. And then basically you need to go through all the acceptance testing similar to dose linearity, dose rate accuracy, independency, verification of multiple gantry angle, and safety interlocks and imaging and mechanical stuff. Okay, so here is a whole list of annual QA procedures for different techniques. Again, I'm not going to go over in detail, but please refer to this table for your reference. As I'm running out of time, so I'm going to go a little bit faster. Just introducing some of the new dosimetry and QI devices from different manufacturers. Again, there are many proton-specific water tank and then one-dimensional water scanners are currently available with a different size of black peak chamber as well from different manufacturers. PTW is also introducing similar types of water tank, and then and recently they have introduced a bigger size of black peak chamber, which enables to capture all the integral depth dose. So this is the recent study we have performed to measure the integral depth dose measurement for different size of black peak chamber, where how much correction factors are needed for each different chambers. So obviously for small size of black peak chamber, which was widely used and not actually capturing all the secondary dose. So you need to make a correction for this type of the black peak chamber, whereas it's not necessary to correct this new Bragg-Peak chamber. Okay, so another new types of QA devices by IBA introducing multi-layer ion chambers and then two-dimensional linear array chambers, which enable us to make our measurement very quickly. And then also scintillator-based the detector can measure the beam profile in real-time basis as compared to film measurement. And then Hitachi is introducing basically integrated depth dose curve and then depth dose curve combined. And then this is an example for spot profiles we have measured in years ago in US, and you see the different shape of spots in different energies, but it is very tedious job to measure all this. But however, it is important to make sure that your spot profiles are as circular as possible and all different angles. So at that time, you know, there's not much software was available, so we have developed our own to identify or to analyze our spot profile, and then depth dose measurement. And finally, I have new dosimetry and QA devices for, you know, measuring the gantry isocentricity introduced by Logo System. I think this is a really good product. You know, you can measure the gantry isocentricity with the radiation is pretty precisely. And moreover, it is very important to manage your patient QA, the machine QA data using this kind of commercially available softwares. Okay, so ultimately, you know, it is our goal to develop the automation of QA in proton therapy, as the beam delivery is very complicated, and with the help from the log file and the imaging system. So we are now in the process of developing our automation of QA program to improve our clinical workflow and to reduce our QA time. Okay, so having talked about this, let's just move to our proton therapy project. So currently we are on the construction of our new building. We're supposed to move to the new building end of this year. However, because of COVID, it's being delayed. So it's about 90% complete. So hopefully it will resume for the construction in 1 to 2 months. So we start our first treatment in 1968. So we have a very long history of radiation treatment in our department. And then we moved to the building in 1980 with the 5 Linux and 1 HDR unit. And then about 19 years later, and then we moved to another new building with 4 Linux and 1 IORT. So currently we are operating 9 Linux and 1 HDR and 1 IORT. So for the new building, you can see here is a 25 4-story building. So we'll occupy the building from B2 to B4, where the proton beams systems will be installed in B3 level, where we have 17 LINAC bunkers in B3 and B4. So we'll relocate 3 LINAC machines to the new building, and then we have already purchased the 8 variant true beams. So we will be installing 11 LINACs, and then we have almost complete our 90% installation for 4 gantries and 1 fixed beam room. So we'll be very, very busier, you know, for next year, and so that hopefully we can open the new building in the end of next year. And currently also we are working on the CT simulator, new CT simulator such as dual energy CT and even MR LINAC in the near future, and 2 Bragg therapy and 1 IORT. Okay, so this is the overview of our proton therapy center. Our vendor is Hitachi. They are offering 4 gantry system with 1 research room here. And as I mentioned, currently there are 3 ongoing proton therapy projects in Singapore. Interestingly, there are all 3 different vendors. The vendors are Hitachi and IBA and Varian. So here is a major specification for our machine. So our treatment room type is 304 rotating gantry, and our accelerator is by Synchrotron base, and our maximum energy is 230 MeV, and maximum field size 40 by 30. So I'm not going to go over in detail. However, there's a unique and interesting feature we have. We have energy change is by multi-energy extraction within 0.5 seconds, so that we can deliver our beam scanning in very quick time. Okay, and then the spot size is also important parameter. So for the highest energy, we have our 1 sigma is 2.5 millimeter. And moreover, we ask for beam matching between gantry rooms for our all 4 gantry rooms. So that we can, in case something happens, we can switch our patients from one room to the other. So this is a new scanning technique Hitachi recently introduced, and the most of the beam scanning is done by spot scanning, meaning that the beam is off during the beam spot move. But whereas Hitachi has just introduced so-called dose-driven continuous scanning, so beam is on during the spot move. So it'll be more uniform, and then the spot sequencing layer can be significantly improved. So we have studied some simulation studies that without losing the coverage or reduction, and then we are able to deliver our proton beam to reduce up to 20%. So the gantry, as I said, this is a full rotation gantry as compared to half gantry. This is more reliable, however, but this is very heavy and very big size. So we have a 6-dot robotic couch, which has a medical gas input and the LAN port, so that we can easily access medical gas and then communication. And then X-ray imaging system, we have cone beam CT and fluoroscopy, radiography, and gating. The image registration is similar to Varian TrueBeam for 3D, 3D, and 2D, 2D, and 2D, 3D as well. So real-time RGPT image-gated proton therapy is another interesting or well-advanced technique by Hitachi, using 2 fluoroscopy images for imaging the markers and then tracking the motion of the markers so that I can deliver your beam very precisely. Okay, so here is a video, but I don't think I have time to show this. But however, again, as I mentioned, with the 2 fluoroscopic images, and then to identify the location, and then you can deliver the beam. Okay, so this is a study from Dr. Shirato's group in Hokkaido. With that respirator-gated proton therapy can improve the dose distribution markedly for moving tumors without lengthening treatment time. Okay, so to summarize my talk, it is guaranteed for the degree of accuracy and reliability required in proton therapy for robust quality assurance program is established. It has similar features with QA in conventional radiotherapy, but some aspects are unique for proton therapy. So TG224 report is very comprehensive proton therapy machine QA as a guideline. So it is important to please refer to this article. And the QA of proton therapy machines are pretty much well described at this point. And then I also introduce proton therapy as subject. So we would like to invite all of you for our World Congress in Medical Physics and Biomedical Engineering in 2021, will be next year. And then moreover, we are preparing our PTCA 2024. Thank you so much for your kind attention.
Anupama, your voice.
Thank you, Professor Song Young Park, for your very informative discussions, and which includes all the techniques you have discussed very well, because this is the very new and updated technology. We should know, all the medical physicists should know these things. You have include in your lectures the delivery techniques, imaging, hold the quality assurance weekly, monthly, yearly, and as well as the image registrations and the scanning guide. All the aspects you have shown very clearly. In the meantime, we have received some questions in the chat box. So the first question from Vernie Convicto, that he asked you that, can you comment on the imaging consideration in proton therapy imaging and how to reduce the uncertainties in the imaging? Professor Park.
Okay, so again, that's a very good question. You know, the imaging, again, it plays a very, very important role to identify your patient position more accurately. So it is desirable to have a 3D volumetric imaging technique you should have rather than planar images, so that you can do your imaging more accurately and precisely. So at the same time, also right now we are also preparing for adaptive radio proton therapy as well. So the imaging plays also another important role to accurately beam deliver.
Okay, thank you. The next questions from the same person. Presently, what are the challenges in the CT imaging and proton planning and best practices to solve this?
Okay, so that's another good question. You know, the biggest problem for using CT images is stopping power ratio conversion from your Hans-Breed unit. From your Hans-Breed unit to a relative stopping power. So at the beginning, CT, single energy CT is being used to calculate or modifying the relative stopping power ratio. However, recently, dual energy CT is being introduced so that you can actually reduce the CT uncertainties, which is from 3.5% from single energy to 1.5 to 2% for dual energy CT. So hopefully we can further reduce the stopping power ratio by introducing actual proton imaging, which we are currently working on it, so that we can actually reduce further range uncertainties. I mean, the uncertainties from stopping power ratio.
Thank you, Professor Sun. So next question from Professor Orun. Can you comment on proton beam energy stability, the range uncertainty, and how to account in dosimetry and in planning?
Okay, so, again, this is another huge topic, okay? So I'm pretty sure I can talk about this more than an hour just for range uncertainties. However, just, to talk about, a few aspects. So this is very important from the beginning of your treatment planning, for example, imaging. So, for example, if the patients has, the artificial denture or some other immunohomogeneity material on your patient body. So the imaging, is also important to obtain, nicely without having any problem in homogeneity material. Or if we saw, and then you need to make sure that it's not, you can actually convert into that. So from that's another important aspect. And then the other thing could be from, you have to reduce your CT uncertainties, based on your image analysis, and then introducing dual energy CT. And then also patient, the motion, and then tumor shrinkage, especially in the case of head and neck cancer. So the tumor is shrink, very dramatically in even a week basis, so that, you need to make sure that the coverage is same as before. So it is, recommended to do that adaptive therapy or another sequence of imaging for retreatment is really desirable. So there are other aspects as well, so, but this is a very important thing, I'm just addressing.
Okay, many, many thanks. The next question is, in many developing countries, the proton therapy machines are not being installed and many countries are planning to install. So what will be the challenges the medical physicists to cope with the skills of proton therapy?
Okay, so again, that's very good questions as well. So when we first start our proton therapy years ago, early 2000, so there are not many centers, as I mentioned. So it was very difficult to acquire the knowledges and all the techniques which we are not familiar with this. Because I'm also coming from the conventional radiotherapy departments. I didn't have a zero experience on proton therapy. So it was very important to, acquire the knowledge and things. So that time, the PT card was given, twice a year, so that we go to the conference and then we ask the expert from the different countries, and then at the same time, of course, there are not many. There's no textbooks, so so we go through our weekly basis, seminar, and then we learn each other, and then occasionally we invite the speakers from different countries, experts, and then we went for that. But right now, for those who are planning to the new proton therapy, you're very lucky because every material is available from even the online. There are many textbooks, and there are many experts in the world, so you can get your knowledge very easily and quickly.
Many, many thanks. Next is how many MPs, medical physicists, do you need for a proton center? Have we enough medical physicists experts in this field?
No, I don't think so. I mean, again, because for last 10 years, so the number of proton therapy centers are growing so rapidly. So I'm pretty sure there's a shortage of proton experts, for those who have proton experience. Still, I'm pretty sure it requires and more. So, even in Singapore also, we have shortage of proton experienced physicists. So what we are doing currently, we are training our people, we are sending to our physicists to different countries, obtaining all the knowledges and experience. And at the same time, again, there are a lot of materials, and then there are a lot of, the videos are available for us so that we can improve ourselves as well. So certainly there's a shortage of proton therapy physicists. So there will be a good sign for our future.
The next question is, what is the depth dose uniformity of proton beam therapy?
Yes, so depth dose uniformity is important to measure because we include in our QA program. Especially this is very important for a double scattering mode where the two beams are used for patching field. So meaning that you match with your distal portion with the proximal portion of different fields. So meaning that if your depth dose uniformity is out of that, and then you may deliver hot to that position or maybe cold. So we should check the depth dose uniformity by using picofans test. So this is there is a reference from our test group chair Bijan Aldomandi. He did some studies when he was at MD Anderson. So I think if those who are interested, then please refer to that document.
Okay, so there are so many questions we are receiving. So I'm pick up some of these because it was, this is everyone would like to know this about updated technology. So from Lalun Yadev, he said that which one is the best for cancer treatment, like MR-Linac or proton therapy? What is your opinion?
So it is hard to compare because, even MR-Linac use X-ray beams, right? With the help from MR imaging. okay, it has an advantage of using high MR imaging, where we don't have that kind of MR-based proton therapy, which I think there is one project is going on, so it should be available in the near future. However, I mean, you cannot compare basically, X-ray versus proton therapy. I mean, there's a huge benefit for proton therapy, as everybody is aware.
Thanks, Professor Park. The next one, I will pick up more 2 questions only. So what is the biological effect of proton therapy than photon therapy?
Okay, so again, that's a very hard topic, and also, the RBE for proton therapy is considered as 1.1 as compared to photon or electron beam therapy is 10% higher. However, this is not really true in the case of different beam range. So there is the RBE increase at the region of prolactic range. So it is important to realize the proper RBE to be applied for your treatment planning. However, this is a very important topic, or a very difficult subject to introduce your RBE. So currently, most of centers are using just a flat 1.1 RBE. However, we are also working, and there are some centers are working to develop the RBE-based, LET-based dose calculation, which we can, calculate the dose more accurately. So it varies from, the patients, from the in vivo to in vitro study, and it has a lot of variables. So there are a lot of studies going on currently. And then I'm pretty sure there's a recent report came out from Harold Paganotti from MGH for RBE for proton therapy. I think the test score report is 156 or something like that. You can Google on your website, get some more information.
Okay. Yeah. The last question is, what is the contribution of the dose of neutrons, protons, and electrons to protons and total dose?
Okay, so yeah, that's a very good question. So we need to concern about that. So that's where it's coming from. So if you are if you're using a cyclotron machine, your shielding is very much thicker than synchrotron. And also because of the, you are using the beam degrading system for your energy change for your cyclotron. So there is a degrader, whereas there's a huge shielding is required, as compared to synchrotron is not really necessary. And then on the other hand, for your double scattering mode, and because you're producing neutrons from the scattering materials and even patient body, so that we need to concern about the neutron production. This is very, very important. Okay. However, with the pencil beam scanning, you can reduce your neutron activation from your pencil beam nozzle. So I guess the new centers are not much worried about the neutron production as compared to old technique. I hope yes. I answer your question.
Yeah, I think so. So last question from me. So how long are you, this quality QA is taken for this proton therapy? How much time is needed?
Okay,
because in
so
linear accelerator,
yeah, that's right. So again, by introducing the new modifying device, by DING or some others, basically you can improve or you can reduce your QA time significantly with daily QA3, or maybe if you are luxury enough, and then you can buy the onset program the device from IBA, so that you can reduce your QA time by 20 minutes or even less. So in general, you don't need to spend too much time for your QA program. So again, hopefully in the near future, we can develop your automation of your QA program, which will reduce more than that. So that will make our life easier, hopefully.
Okay. Many thanks, Professor Park,
No
for your
problem.
very informative. And I will also, we have seen more than 126 participants have attended this webinar, and this is a great one. And also I would like to request again the participants, you have seen in your chat box, the CPD links are given. So please go through the link and fulfill the forms to get the CPD certificates. Please write to Jean or Chai Hong to get your certificate. And now I am just hand over to Professor Orun to complete the program. Thank you.
Thank you, Professor Anupama, for excellently conducting the webinar. Thank you, Professor Sung Yong Park, for giving the excellent talk on proton therapy, which is a very complex, and you need a very specialized knowledge and training about implementation of proton therapy. And some of the participants has asked that few countries have, many countries do not have, how to cope up with this, and that is the job of the AFOMP to make such kind of webinar. So at least the medical physicists who are not having the exposure to the proton therapy, they understand, and such topics we are covering along with the routine topic. So thank you, Professor Sung Yong Park, for
You're very welcome.
And also Professor Anupama for conducting this session. Sorry for these things.
Yeah, thank you all.
Thank you, just a moment. And then thank you, participant, for actively participating in this webinar. The webinar recording will be available on AFOMP website in 2-3 days. In this series, the next webinar will be on 3rd September and will be by Professor Ghulam Abu Zakaria, and he will speak on dosimetry of small proton radiation fields, comparison of IAEA TRS 483 and the German DIN 68098 protocols. So I look forward all of you that you join through this webinar. In few days time, the link to this webinar will be available on the AFOMP website, and also we will circulate to the participant with whom we have got the email IDs. Once again, I thank Professor Park, Professor Anupama, and also Rajini Verma, who has taken the technically arranging all these things. And unfortunately today our ETC chair, Jin Xian, could not join, but we could do it successfully. With these things, I hand over the floor to Rajini Verma to compile the things and say goodbye.
At last, I want to thank the whole webinar team, Professor Chogle, Professor Anupama, and especially Professor or Dr. Park for such a scientific feast. And I request participants again to use the link for their certification. And I want to give one more information about that. We have received many emails regarding why certificates are not issued to them. So it is subjected to at least 40 minutes of participation, and that link has to be used earlier, within maybe 2 days, not far from there. So I thank you all once again for such an active participation. And as Professor Chogle has informed us about our next AFOMP webinar on 3rd of September, we are hoping and we are looking forward to have you all with us, even more in number and with active participation. Thank you so much.
Until then, see you. Have a nice time in this COVID-19. Stay safe. Thank you very much.
Thank you very much. Thank you all.